Ken Landau. Thanks for watching. Let's talk about fibroids, the most frequent tumor of the female reproductive tract. It's composed of smooth muscle cells together with some fibrous connective tissue. It develops either in or on the surface of the uterus. Uterus sits between the bladder and the bowel, so it might cause some symptoms in those organs as well if the lesions get large enough. Fibroids are also referred to as uterine myomas or leiomyomas. They're called fibroids because they were thought to be composed principally of fibrous tissue, but they're not. They're principally composed of smooth muscle cells. They're benign tumors. They're not cancerous. They don't get to be cancerous, and they're extraordinarily frequent, so that it's estimated that somewhere between 20 and 80% of all women have fibroids. For the overwhelming majority, they're not diagnosed, but that means about 100 million women in the country have fibroids. Symptoms could either be non-existent or non-specific. They remain undiagnosed in the majority of cases, but in somewhere between about 20 and 35% of women, they may cause some symptoms that can interfere with the quality of life. The onset, at least as far as the diagnosis is concerned, tends to be somewhere in women in their 30s or 40s, very infrequent in teenagers, but they start to be diagnosed in the 20s and then in the 30s, of course. They tend to improve after the menopause, so that we know any growth of lesions that we think are fibroids that occur after the menopause, they need investigation because it's probably not the correct diagnosis. Now, even though fibroids are so extraordinarily frequent, we find that on clinical examination, only about 1 in 3 fibroids can be identified. The majority of fibroids are not identified. With ultrasound examination, we can increase that to 50%. On microscopic examination, it's still only 75% of lesions are diagnosed. Now, most women have multiple fibroids, and the fibroids are of varying size. So they can range anywhere from the size of a grain of sand to a pea to maybe a golf ball size or a tennis ball size, even the size of a watermelon. We find that some women develop abdominal distension and it looks like they're maybe 16 or 20 weeks pregnant. That could be the result of a fibroid. Well, do they grow at a constant rate? No, they don't, interestingly. Some of them grow relatively slowly, some of them grow relatively rapidly, and some of them don't change at all. They can have their own growth spurts, and sometimes a growth spurt is because of the lesion getting larger, or sometimes it's because of a complication like hemorrhage into the lesion or necrosis of the lesion or a cystic change that develops. And after the menopause, frequently become calcified. Well, remember, they should stop growing at the menopause. How many lesions do women have? Well, that's interesting too. Since we can't identify the majority of lesions, we don't know. But most women seem to have anywhere between 1 and maybe as many as 25 lesions. Most women somewhere in between. And they can be of different sizes. And the extraordinary thing is that in an individual woman, some of the lesions can stay the same size while others shrink, others grow. Don't have any explanation for this. Well, what about ethnicity? It seems that women who are African American tend to have the greatest incidence of fibroids. Then in the intermediate position are Caucasian women and Hispanic women, with Asian women having the least. Now, if we look at African American women, they are 2 to 3 times at greater risk. They tend to come on at a relatively earlier age. So overall, in the Caucasian population, the diagnosis is made generally around women in their 35-year-old age group. But in African American women, it's about 25 years of age. And interestingly, African American women have more lesions and they grow more rapidly. No explanation for that. Family history, yes indeed, seems to be a genetic component to the lesions. So we know that if a mother or a grandmother has the lesion, your chance of having fibroids, these diagnosed fibroids, are anywhere between 3 and 6 times greater than the average population. And if your identical sibling has fibroids, then you have a much greater chance than if the sibling happened to be a non-identical twin. Well, additionally, it seems that those women who have the onset of their periods relatively early in life seem to be at greater risk. And we also know that women who are heavy, women who are either overweight or obese, seem to have more problem with fibroids. Fibroids seem to grow because of the fat cells. The fat cells produce certain kind of chemicals, hormones, and those hormones tend to stimulate the smooth muscle cells and their growth. So we know that if you look in a culture dish and we put the smooth muscle cells together with some adipose cells, fat cells, we know that the smooth muscle cells are going to grow more rapidly. And women who are overweight seem to have a decreased concentration of sex hormone binding globulin, which means there's more free hormone around. And it's the free hormone, not the bound hormone, that seems to cause the problems. Now, if we classify the lesions of fibroids, we can classify them as growing in the wall of the uterus. That's about 60% of all lesions. They're the most frequent, of course. Submucosal lesions grow just above the cavity and actually protrude into the cavity of the womb or the uterus. That's about 10 to 20 or 25% of women. Sometimes involve the cervix, usually not. And then we have the subserosal lesions. Those grow on the outside or the pelvic side of the uterus. That's another 10 to 25% of women. They can grow in a sessile fashion. They can be what we call pedunculated or grow like a mushroom. They can grow from the submucosal surface into the opening of the womb, or they can grow from the subserosal surface into the pelvic or even abdominal cavity. And then sometimes they can detach from the womb, and then they're what we call parasitic fibroids. Well, why do fibroids develop? We haven't the slightest idea. The idea, of course, is something to do with genetics, something to do with hormones, something to do with growth factors. And then we have the xenoestrogens, and the xenoestrogens are the endocrine disrupting chemicals from the DDTs and the bisphenols and the genistein and the PCBs, and we don't really know what the role of those is. Some people are highly suspicious. Most people think it's not probably a major issue. Now, it appears in those women who have multiple lesions, and we said many women have 5 or 6 or 7 of the fibroids, it seems that they're genetically unrelated. It's not that one caused another one to grow. It's if we look microscopically or if we look genetically, they have different genetic patterns. Well, where do they come from? They seem to come from stem cells, or they seem to come from primordial cells. Tend to be related somehow to pregnancy, so they grow during pregnancy, probably because of the estrogen. After the pregnancy, they tend to shrink or even disappear completely. But remember, if they grow after the menopause, then we have an issue. Well, what kind of symptoms do people develop? It's really tough to say because the overwhelming majority of people who have fibroids don't even know they have fibroids, and they don't cause any symptoms. But if they are going to cause symptoms, the most common type of symptom is a problem with bleeding, either bleeding during the menses, extra heavy, or bleeding in between the normal periods. Some women develop some pelvic pressure, some women develop pain, all depends where the lesion happens to be. Sometimes the abnormal bleeding can be so heavy that women can develop an anemia. And the anemia might be the reason that they go to see the doctor, because they're complaining of dizziness or lightheadedness or shortness of breath, even some chest pain. And then we can have some pelvic discomfort because it can press on some of the surrounding organs. So women can have complaints of bloating or increased abdominal girth, or sometimes frequent urination, especially when they're lying down. Or it can obstruct urination, so women can have difficulty emptying their bladder, and some women have low back pain or leg pain, especially when they bend down. And then we have endometriosis, and endometriosis is one of those conditions that seems to go along with fibroids. We'll talk about that later. Less commonly, some women have some constipation complain of pressure on the rectum or rectal pain in some women. Sometimes the lesions put pressure on the tube that connects the kidney to the bladder, and then you can develop a hydronephrosis. Infertility, that's not usually an issue with fibroids. Now, sometimes it might interfere with the peristalsis of the uterine lining, but usually that's not going to be a significant problem. If there is a problem, woman probably has endometriosis. It's sometimes more likely to interfere with the pregnancy. So you can get pregnant, but sometimes it increases the rate of miscarriages by 2 to 4-fold, might cause a woman to have a cesarean section. Depends where the tumor happens to be in the uterus. How do we make the diagnosis? Well, clinical examination can feel the mass sometimes. Sometimes it's ultrasound examination, a transvaginal ultrasound. Sometimes it's as a result of an endometrial biopsy or a D&C because we're excluding cancer, excluding endometriosis. Sometimes it's laparoscopy or a CAT scan or an MRI. Or there's a gadget that's sort of a mini colonoscope. So everyone knows about colonoscopy, where we look into the large intestine. Well, we have the same sort of device where we can look into the uterus, into the cavity of the uterus. That's called a hysteroscope. Woman who has complaints that might be fibroid, we have to think of a variety of other kinds of problems. Maybe the bleeding is due to a thyroid problem, or a woman might be miscarrying. Maybe it's a uterine cancer or a pelvic infection. Maybe it's an ovarian neoplasm. Maybe it's a similar tumor to the fibroid, but it's with the uterine glands mixed with some small amount of smooth muscle cell. We call that adenomyosis. Maybe it's the endometriosis. Maybe it's a bleeding disorder. Maybe it's because of an IUD. Or it could be cancer of the uterus, and all of these things have to be differentiated. But remember, cancer of the uterus is not related to fibroids. Fibroids develop from one cell, one primordial cell, a progenitor cell, or a stem cell, and that's where they grow. Now, we learned recently that the control of the growth of a fibroid has something to do with some of the other cells, not the smooth muscle cells, but some of the other cells that happen to be in the fibroid, in what we call the extracellular matrix. Or it might have to do with some of the cells surrounding the fibroid. Well, there's frequently an association with endometriosis. And endometriosis is also extraordinarily common, estimated to be present in maybe 10 to 50% of women, causes dysmenorrhea, painful periods, causes chronic pelvic pain, maybe some dyspareunia, pain during sexual activities, may interfere with fertility. The two are so frequently combined that in one study, looking at a tertiary medical center, a referral medical center, where women were referred for evaluation of fibroids, actually 87% of the women who were thought to have fibroids also had endometriosis. Only 9% of the women only had the fibroids. So the two very frequently are mistaken, one for another, at least as far as the symptoms are concerned, and sometimes as far as the other issues are concerned. Now remember, the fibroids, since they're asymptomatic, the overwhelming majority of women who have them need no treatment. If the lesions are symptomatic, then all depends on how symptomatic to decide what kind of therapy. If minimal symptoms, then watchful waiting is probably good. Some women believe that green tea or milk thistle or chasteberry or fish oil might help. That's fine. Probably doesn't, but it's worth trying, certainly harmless. Non-steroidal anti-inflammatory drugs can help with the pain around the time of the menses. Sometimes a birth control pill can decrease the amount of blood loss. However, they don't shrink the fibroid. By the same token, an IUD that contains progesterone, the levonorgestrel is the one in the United States, well, that can be used. That thins the lining of the uterus, so it decreases the bleeding, but sometimes it's a little difficult to put the IUD in the womb, in the cavity, because of the distortion, depending on where the lesion happens to be. Then we have the GnRH agonists, and that causes a woman to have medical menopause. So there's a problem with that. And the problem with that is even though these kind of medicines can decrease the size of the fibroids by 50% in as short a period as 3 months, can only use the medicine for a period of less than 6 months, typically used to shrink the lesions before surgery. But unfortunately, they're associated with osteoporosis and headache and insomnia and depression and menopausal symptoms. So they're not really a long-term use. These are medicines like Lupron or Buserelin or Goserelin, those kind of medicines. And oftentimes, since they turn off the ovary's ability to produce hormone, then sometime, not infrequently, have to add back some of the hormones so that the women don't feel so miserable while they're taking the medicines. Then we have medicine like the RU486 or mifepristone, and that can be used. That can decrease the size of the lesions quite dramatically, typically used pre-surgically. That's the mifepristone is the pill that's associated with the emergency contraception, the abortion pill it's very frequently referred to as. Then we have the aromatase inhibitors. Those are more typically used to treat women with breast cancer. But what they do is they stop the change of male hormone into female hormone. So that might be helpful. Danazol used to be used, but danazol, even though it had anti-estrogenic effects, and even though it decreased the bleeding, it didn't shrink the lesions, and it had androgenic effects. Now, there are some progesterone receptor modulators, also called the selective progesterone receptor modulators. Ella is one of those pills. Ella first came on the market as an emergency contraceptive pill. Then it was thought to decrease the size of the fibroids, also decreases the uterine bleeding. And it was thought that this might be a significant answer. Well, everybody got excited about it, and as a matter of fact, the drug manufacturer applied to the FDA to get the drug approved for treating the fibroids. It was very frequently used off-label, but in August of 2018, the FDA said, hey, not going to do it because it tends to cause liver damage. It's been associated with liver damage, and as a matter of fact, just in March of 2020, the European Medicines Association, which is the equivalent of the FDA, but in Europe, they said, don't use this medicine for fibroids. It tends to cause too much problem. So as a result, this once promising therapy seems not to be appropriate. Now, Bayer was making a medicine in the same family called Villapresin, and Villapresin was thought to have all the benefits of Ella, but unfortunately, during animal studies, they had to halt the experiments, halt the studies that were also going to treat women because they found liver damage. Now, AbbVie, they make the Orilissa. They just recently received approval in May of 2020 to market their drug, the Orilissa, but they're going to put it together with estradiol and with norethindrone. That's estrogen and a progestin. And what they're going to do is they're going to call it not Orilissa, but now they're going to call the medicine Orian. But the basic ingredient, of course, is Orilissa. Now, should you take it, or is it going to be later found to be associated with liver disease just like the other medicines in the family? I think you have to keep an open mind. Well, there are a variety of other treatments that are available. They're not used very frequently. There's the magnetic resonance guided ultrasound that's used sometimes. Myomectomy is a relatively popular treatment where women want to continue to have children. So the tumor itself, the fibroma or the myoma is removed and the uterus left intact. That's a relatively conservative approach. Some people use uterine artery embolization, where they put material into the artery that goes to the uterus so that the uterus actually sloughs and dies, but it has a relatively high rate of complications and recurrence of the lesions. Uterine ablation, or endometrial ablation can be done, but it only works if the lesion is relatively close to the inner lining of the uterus. Otherwise, the lesion isn't in the field where it can be treated. Lesions can be treated with the hysteroscopy, with a resectoscope, sort of like they used to do on the prostate. But unfortunately, that may be associated with significant bleeding loss. Then there's hysterectomy, vaginal hysterectomy, laparoscopic hysterectomy, abdominal hysterectomy. Well, actually, that's the #1 treatment in the United States at the present time. But you have to remember, if you take the uterus out, then the ovary itself, it's not going to last very long in the absence of the uterus, going to have a decreased survival by about 3 to 5 years. And some women are very happy because they feel that they're liberated from the problem, but other women say, hey, it's interfered with my sex life. Well, hysterectomies, about 600,000 are performed every year in the United States, and 200,000 of those hysterectomies due to fibroids. Well, fortunately, the operation is relatively simple, relatively straightforward, and that's the story of fibroids, or leiomyomas, or simply myomas. They're extraordinarily frequent, often associated with abnormal bleeding or excessive bleeding, sometimes with abdominal discomfort, frequently associated with endometriosis. Lots of women seem to have the lesions and have absolutely no symptoms, not aware of it. So just because of a diagnosis of fibroids or uterine myomas doesn't necessarily mean any treatment is necessary. But if treatment is necessary, we have a variety of treatments available. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.